Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami for our Monday afternoon Instagram chat. Today's topic is using a gestational carrier. When is it right for me? And if we go back to basics, in order to be successful in having a baby, we need three key ingredients. We need good quality sperm, we need a good quality egg, and that embryo needs to implant in a relatively normal uterus. And then obviously the job of the uterus is to act as an incubator for the embryo, nurture the embryo, allow that embryo to grow and eventually give birth. So the part of the system that we're talking about is really the uterus and there are two basic categories of when you would consider using a gestational carrier. The first is medical reasons, and the second is social reasons. With medical reasons, the obvious reason of why do I need a gestational carrier is if I don't have a uterus. Some women have had their uteruses removed due to medical problems such as fibroids or cancer. Some people have had endometrial ablations for abnormal bleeding or even sterilization purposes and changed their mind and they want to have a child, and that's not a type of sterilization that's reversible. And other medical problems when the uterus is present and hasn't been removed but is not functioning properly. And that can either be from fibroids that are present that are inoperable, or the patient doesn't want to have surgery. Small fibroids are not a problem. Fibroids that distort the cavity of the uterus, that are large and multiple in nature, can predispose to either miscarriage or implantation issues. And then the latter category would be endometriosis involving the muscle layer of the uterus itself, and that's called adenomyosis, and that's much more difficult to diagnose and much more controversial on how you treat it and at what point do you say, okay, my uterus isn't working. So the first category is if there's a medical reason that the uterus is not going to be receptive to an embryo sticking. The second category is social. There are some patients that, for whatever reason, just don't want to carry a pregnancy. That reason may be just because they don't want to see themselves pregnant. They don't want to be pregnant or deliver a child and would like somebody else to carry it for them. And that's also okay to utilize. What you're doing with gestational carriers, you're doing in vitro fertilization, and you're taking the eggs from the intended parent, fertilizing that with the sperm from either the intended parent, if it's a traditional male-female relationship, or with donor sperm if need be in a same-sex marriage situation. And then placing those embryos that result from in vitro fertilization, you fertilize the eggs with the sperm, let the embryos develop for 5 days, you can biopsy them to make sure they're normal, and then selectively put back, usually one embryo at a time, into a gestational carrier to carry the pregnancy and give birth. Obviously in a male-male same-sex marriage, we have lots of potential avenues of sperm, but not a uterus to work with, and we're obligated to use a gestational carrier in that situation. So the methodology is pretty straightforward. It's IVF. The only difference is instead of the embryos being placed in yourself, the embryos are being placed in a third party. There's also certain situations where no matter what we do, somebody doesn't get pregnant. We don't know why. And we'll work up the couple for causes of implantation failure and recurrent miscarriage. And if you have somebody that's having recurrent miscarriages, no matter what we do, and there's no obvious explanation, or the lining of the uterus is not thickening up adequately, and there's nothing we can do to correct it, and then one can say, okay, let's use a gestational carrier. One of the questions that we get asked sometimes is, okay, how about if we use a gestational carrier because it'll increase my chances of getting pregnant? And that's okay if the reason you're not getting pregnant is the uterus isn't working. A lot of time, it's interesting, I get asked the question when the woman has diminished ovarian reserve and their eggs aren't working that good, and that that they say, okay, if I'm not getting pregnant, what if we put it in somebody else? But using a gestational carrier to carry the pregnancy, to act as an incubator, doesn't solve the problem of the quality of the eggs or the sperm, basically. So it's not a treatment for diminished ovarian reserve. It's not a treatment for eggs that aren't very good quality or embryos that aren't normal. It's only a treatment for when you have a normal embryo that's not working, and then we're going, okay, we're throwing the uterus under the bus. The uterus isn't working, so let's use somebody else's uterus. The questions that come up when you're using a gestational carrier, first is this okay, is this right for me? And we've gone through the medical and social reasons why that would apply. The second issue is what do we need to do to make sure that we should proceed? The American Society of Reproductive Medicine recommends that any couple using a gestational carrier have at least one session with a psychologist to go through the concept of using a carrier and make sure you're comfortable with it. And we can refer you to people that provide those services, and as well as general fertility counseling and just good support mechanisms. But they want to just make sure you're okay with that person. The second aspect is, where does the gestational carrier come from? And the gestational carrier can be somebody that you know, that's a friend or a relative who is willing to carry a pregnancy for you. It can be somebody that you meet as a result of your quest to find a gestational carrier, and we have patients that have done this independently where they've searched for carriers. Most of the patients find a gestational carrier through an agency. These are what I would refer to as modern day adoption agencies, but they deal more with donor egg and gestational carriers, and they specifically are recruiting patients, subjects to act in that role, basically. A good gestational carrier obviously is somebody who has a normal uterus, because that's what we're trying to achieve. They should be younger rather than older. Certainly under age 40 makes sense, and that's based on the fact that we want them to have a low risk of pregnancy complications. They should have preferably had at least one childbirth, so it's not a new thing to be pregnant, and they understand what childbirth is and so forth. And we will go through their records. Once you select the gestational carrier, the agency usually will send us a set of their medical records, their obstetrical records, their medical history. And before we even meet the gestational carrier, we go through all this to make sure that there's nothing obvious that would preclude this person from acting as in your behalf. It's a known relationship, and you want this to be a known relationship. In contrast to selecting an egg donor or a sperm donor, you can know or not know who the donor is. But with a gestational carrier, this person is going to be carrying your child, and as attendant parents, you need to have a relationship with them and foster that relationship. And you need to make sure that you have a bunch of good discussions with the gestational carrier before starting the process to make sure that you're all on the same wavelength. From a practical side and a legal side, the baby that is being carried belongs to you and your partner. However, while the gestational carrier is pregnant, the decisions that take place when they're pregnant are made by the pregnant person. So it's important that you have an agreement with how many embryos are going back. There, our best recommendation is one, occasional two, but certainly no more than that. you need to have an agreement on what happens if there's a finding that the baby's not normal. Are we going to give birth to a abnormal child? Are we going to terminate a pregnancy? There are not right or wrong answers to these questions, but it's important that as intended parents, you're on the same wavelength as the gestational carrier, so that you are both doing the same thing. You're both on the same page of decision making, basically. The gestational carrier doesn't necessarily need a cesarean delivery. If they don't have a medical reason to need one, they can have a vaginal delivery. That's not a problem. And it's important that the gestational carrier be screened, and we will screen them for infectious diseases before they get started. They'll be screened again before embryos are put back in. They're screened for drugs at least one time, and their medical history is gone through in great detail to make sure there's a compatible relationship. The issues of financial arrangements between you and as intended parents and the gestational carrier are done independently of our office. The agencies deal with that. They all have attorneys that they work with that will help develop that relationship. And one of our jobs as your physician and taking care of both you and the gestational carrier, one of our responsibilities will be, when asked by the attorneys during pregnancy, we will provide an affidavit that basically says that the biologic origin of the baby that's being carried by so-and-so is a result of a medical process with the intended parents' eggs and sperm, so that there's no question that you're the parents of that child. That plays a role down the road in that, one, after delivery, the attorneys will arrange for the original birth certificate to be sealed and a new one issued with the intended parent as the mother. And the second thing and most important thing is that while the pregnant gestational carrier gets to sort of decide what's happening medically while she's pregnant, once that baby is born in the delivery room, you now have a separation of the mother and the baby, and certainly the birth mother gets to determine her own care, but the disposition of any specific treatment for a newborn baby would be based on you as the rightful parents of that child and not the birth mother making those decisions. So you need all those things in place before things happen, so that you are the parent of that child, you're the decision maker of that newborn baby if there is any issues, and so forth. The use of a gestational carrier, this has been done for years and years. We have an active third-party reproductive program in our office, both with donor sperm, donor eggs, and gestational carriers. The key things to remember are that using a gestational carrier doesn't do anything for the eggs or sperm. You still need a good quality embryo to put into the uterus, or else it's not going to work. It's something that should be thought of. Obviously, if you don't have a uterus, you can still have a baby that's biologic as long as you have ovaries. And we can use a gestational carrier. You can use a gestational carrier if there's a medical reason why you shouldn't get pregnant. You have severe hypertension, diabetes, some other things that really won't prevent us from getting eggs, but might not be the safest thing for you to carry a pregnancy. And in that case, certainly, even though your uterus might be fine, using a gestational carrier may be a better idea. Certainly, if you have disease in the uterus that would make it more difficult for an embryo to stick, or have had a history of recurrent losses that are unexplained and not fixable, and using a gestational carrier is another option. And lastly, we have some patients that for social reasons just don't want to physically be pregnant, and they too can use a gestational carrier, as well as the same-sex marriage with two men, where obviously they're missing a uterus and a gestational carrier plays a role. So all of these are great examples of who might need a gestational carrier. The methodology is using in vitro fertilization, and I hope this is helpful for those of you that have questions in this mind, and please feel free to contact us with any questions if you're already patients of ours. All three of us, Dr. Ackerman, Dr. Chung, and myself, are very well versed in this area. I'll be happy to further discuss it with you. So have a good day and a good afternoon. Stay safe. Best. Bye-bye.